Hello, Claire Thomas. I'm one of the event scholars. Thank you very much for your talk. It was really interesting, and I think it's an extremely important area that we do collaborate for this mutual innovation in the future. One of the problems that I feel personally that I know some of my other junior colleagues would probably reflect is that with a heavily financially driven industry such as the pharmaceutical, or big pharma as it has been called previously, the difficulty with this trust issue for many of us lies with these uneasy ethical considerations and how we marry that with our duty as a doctor. When we have reports of exploitation of vulnerable populations in trials, particularly in developing countries, biased publications, manipulation of patenting laws with Me Too drugs and political lobbying. I'm not saying that's still prevalent today, but how do we, as clinicians, how do we get past that, and how do we rebuild the reputation of pharma with the clinical industry so that it does marry up with our ethics as we see them? My main issue being that my goal as a clinician is to maximize health in the true definition: social, mental, physical, psychological. And I find it difficult sometimes to engage when I'm concerned that the organization I'm engaging with might be contradicting my objectives elsewhere.
When I joined AstraZeneca, one of the things that really surprised me was the extent to which people that worked for AstraZeneca described themselves as working in healthcare. And I was genuinely quite puzzled by this, because I think perhaps like quite a few people that work in the NHS, I tended to equate the NHS and healthcare as being, you know, one and the same thing. Certainly in this kind of country, I'd actually put them together. I think that we can overstate the differences between the two sectors. I can't get away from the analysis of a profit motive and bottom line. But if we reframe that as efficiency and value, then I think those same challenges and those same obligations are beholden on a public service. So whilst not taking away from the profit line stuff, and that's different from the NHS, I'm actually much more struck by the similarities and the differences. And many of the people that I met working in the pharmaceutical company were absolutely passionate and got up every morning to go to work to improve healthcare and to develop effective medicines that would improve healthcare. So I think we can perhaps sometimes overstate the difference stuff. But I think the other part of the answer that I would give to you is to say that I'm very mindful of seeming like I think this can all be about some new cosy era of collaboration. And if I've got longer time to present, or in the past I've got a slide that talks about different domains of the relationship between the NHS and their industry, because I think there is a part of the relationship that can be collaborative for mutual benefit. I think there is most definitely another part of the relationship that will be commercial and that will be competitive and where our interests are not aligned. Industry will work very hard to maximise their prices. It is right and proper that the NHS works equally hard, if not even harder, to tighten down those prices. So I think the trick for us as leaders is not to be in a binary mode of saying either compete or collaborate. It's about being able to operate in both domains of leadership at the same time, and recognising when we can collaborate, but also recognise when we are competing and compete. And I think we need to be able to do both.
Thank you. Can I ask Andrew, just developing that theme, we promised when we set off to build the HIAC that we would develop close relationships with pharma and industry, and it just never happened. And I'm not sure why it didn't happen, but it was difficult to persuade everyone that what the value was there, and people saw it as being risky. So I just wonder, from a research point of view, if you've got examples or a view as to how research and pharma have collaborated to make us feel more comfortable, because we're more at the spreading innovation and getting things down to grassroots.
Okay, can you hear me? This is with my Scottish hat on. In 2006, we signed a Scotland-wide agreement with Wyeth, now Pfizer Pharmaceuticals, for £50 million to co-develop proof of biology studies. And I think the type of relationship is important. Some of the brightest scientists I have ever met work in industry. Fact. Second fact, name me a drug which last came out of academia. there are very, very few. So we are obliged for our patients to work with pharma in constructive ways. I think if you look at the drug discovery process, where we target engagement with pharma is where there is an intellectual contribution from the academic community to work with their industry colleagues for proof of biology, so that we can reduce this unacceptable, what they call the valley of death, which is phase 3, because it's in no one's interest. It's not in industry's interest, it's not in the economy's interest, and it's not in patients' interest for drugs to fail at phase 3. So what we've done is work earlier on in sort of proof of concept phase 2 studies in a collaborative way. And I think where you're making an intellectual contribution, that is really important. So that would be my first comment. Another brief comment. I think in the UK, if I go to my friends in the States who are in academia, many of them have worked in industry, and there's a bi-directional flow of intellect, whereas we've sort of got the NHS or public sector running through us. But I think we've got to be far, you know, we live in a market society, and we've got to be far more open-minded about how we engage with the commercial sector.
And I think research in its links with industry is ahead. In education, we haven't linked at all as yet.
Yeah.
I mean, there's the occasional, we do training programs for some of the pharma companies, but that link just doesn't exist. But I think what you're saying to us in education is we should make those links.
I think so. And I say to my lot in Scotland, you know, even if we cut the Scottish budget to 20 billion, currently it's 30 billion, no, that won't create growth in the economy, which is what we need. So we have a responsibility in spending £20 billion a year to try and derive some economic benefit out of the far end. Currently, the royalties to Scottish universities are about £3–4 million a year from intellectual property realisation, and that is nothing. So we've got to be far more business-minded about how we derive benefit from our intellectual property, and that will involve commercialisation.
Good afternoon. Kevin McGee, Chief Executive at the George Eliot Hospital. Mark talked about the dangers of this naive transplantationism. But earlier in the day, we've talked a lot about evidence-based practice, about the need to reduce or improve standardisation in terms of practice, about rolling out good practice. So there seems to be a balance that needs to be struck there. I just wonder whether the panel have got any ideas, any suggestions about how we can get that balance between trying to get standardisation in terms of practice, but not doing anything that's too naive and trying to get silver bullets that don't exist.
There's someone talked about reinventing the wheel. A friend in America said, no, the big problem is reinventing the flat tire. The one thing we mustn't do is repeat what people do wrong. The second approach that's very important is to recognise, it's first described in a book called Vance Packard. It's almost as old as the Everly Brothers. It's about 1957 or something. It was the first book about advertising, The Hidden Persuaders. And Mary Baker Cake Mix, which came to Glasgow when I was a boy, was a miracle of making a cake out of a box. But they didn't sell until you took the dried egg out and let people break their own egg in. And my work with the map of medicine and think of nice pathways, it is this localization that's very important. I think that our discussion in the workshop earlier on, what I'm keen to follow up here, supposing we decided there should be 12 asthma networks in the Northwest, then they wouldn't all be exactly the same. Some would have randomized trials running in them, some would have a voluntary group, or they'd have different approaches. So I think the thing is to move much faster to making decisions about what's best value practice, nice pathway or something. Secondly, think about ways in which you would define what the population base is and get the patients involved in that. And then encourage people to break in their own egg. And that's why I've used the map of medicine, like I used the atlas, for its emotional benefit. So people feel they are doing something. Our people see a physio before they see a nurse. Terrific, you know. Does it matter? And if it does matter, let's do a trial. If it doesn't matter, localize. So I think it's been far too much. When I did set up the public health, the commissioning network for, I mean, PCTs were telling me they didn't want to share good practice because the other PCT might get more points in world-class commissioning. I mean, what the hell is that all about? Well, that's not going to happen again.
Yes, this is a challenge that I deal with in Brussels quite a lot, because moving up a level, there are 27 countries in the EU, and I'm doing a piece of work at the moment on the future of e-health. And we've just been on a study visit to Estonia, where they were very proud to show us their very cutting-edge e-health system and e-governance. But the question there is, they've got a population of 1.2 million. It's relatively easy for them to bring up to scale very quickly. And also, they don't have any legacy systems. When the Soviet transition happened, they could start from a blank sheet. And so this was the criticism from our group, that was an international group. And we said, well, it's all very well in Estonia, but you have it easy. And they came back and broke down for us the entire process that they'd done, which was about building up trust amongst the population, understanding where the barriers were, exploring what the issues were that the physicians were putting on the table, where the resistance was coming. So we were able to look at the process that they dealt with and realize that there were examples and useful information we could take elsewhere, rather than naively saying, let's make Estonia the example for the rest of Europe. It's not going to work elsewhere, but we can learn from the steps they took, some of which they told us, you know, we did that in the wrong order. So the messages we were getting are, you need digital ID and digital signatures sorted out before you go to e-health, because until you've got that, there's no trust in the system. So I think the message that I would take, and is extremely useful for me to hear at this conference, is the collaboration is useful, and there is a strong reference for a need for an evidence base. But the other message that was coming through very strongly is we have to take risks. If we're going to innovate and change, we're going to take risks. But to do that and reduce the risk, we need the relationships. So several organizations and individuals are involved, and the learning can be shared. And the big challenge is the protectionism that we heard about, and is a barrier. When you have competition in the system for quality, that's great. But if the competition becomes such that nobody's prepared to share their data, either their failures or the successes, the system becomes paralyzed. And that, I think, is the biggest challenge, is finding a system that allows competition to drive up and push innovation, but doesn't become paralysis.
The question is, how do we do it?
Right,
how do we get your brilliant research to the front line?
Yeah, I think, number one, focus on the patient. That's what we always try to do. Secondly, everything that we've tried to achieve has adopted the network model, which you're beautifully outlined. So we've moved away from hierarchies towards collaborative networks. So there are 14 diabetes networks in Scotland. They're all a different state of maturity. Some of them patients chair. So you've got the patients chairing the professoriate, and that's great. So we use the network model. Thirdly, what I call free the data. There's an IHI lady who says, in God we trust, everyone else needs data. And I subscribe to that. We need to free the data to the front line. And the days of historical audits gathering dust on the shelf should be dead, actually. You know, what we're trying to do is feed the data to the front line in real time, so that they can make real-time decisions on how they change their practice.
Can I just comment on the issue about pharma? But first, I feel that the drugs, what I've been engaged in the last couple of years, drugs have been criticised a lot, and that's partly, you know the story about the person sees the drunk looking for under the lamppost for the keys, and they say, well, I'll help you. Where do you drop them? And the drunk says, over there in the dark. And they say, well, why are you looking here? Well, the light's here. And the drugs have had quite a tough time because there's evidence. look at what's happened to CT, for example, in the last 5 years, or follow-up visits. There's lots of areas of the health service where there is no evidence at all. And that's a lot of wasted. And it may be, we have to think of healthcare as a knowledge business. Now, the human genome is a form of knowledge. It's a representation of knowledge. But I don't feel we play enough to our strengths. People, I'm now starting in the half of my life that's not NHS to work in Germany, France and Italy. And people that are really interested in the NHS. They know it's a very good buy. Germany's a complete mess of crazy competition between insurance companies, hospitals and individual doctors. Now, the political change would be necessary, but starting to think of, if we did get some systems, I've been trying to encourage different parts of England, Scotland already does it, I think. You see, 5 million is about the same as a province in Italy, as a region in Italy or a province in Spain. And there is a knowledge business there to be done. And what people are looking for would be things like systems. So, because we just happened to hit the buffers early, 2 years early because of the bankers. Everyone else is hitting the buffers. Germany will hit the buffers because of Greece. They can't avoid healthcare costs. So I feel there is an important market and knowledge. Now, Raj is here. Raj, would you like to comment? We've been discussing with India, for example. I mean, you go to India, the American universities are all over India. God knows what they're selling them, and because the one place you wouldn't copy is the US. But of course, the US has got, as someone said, we've nothing as good as their best, nothing as bad as their worst. They have got very good accountable care organisations, but maybe we should ask Raj to say a little bit. He's got an idea how Manchester can build the traditional links with India, but they're not looking for us to go up with new drugs. They're wondering what the hell are they going to do about
systems,
rising need and demand, and no more money.
I'll be very brief. Basically, the idea was to see how we can leverage all the intellectual capital we have built over the years in the UK, and see how it can be used in some of the emerging countries. And India is just one example, because health and education are the two largest growing sectors now. When people think about business, people forget that health and education are huge businesses now. And in places like India, there's a phenomenal amount of money going into it, and what they need is that kind of intellectual support. So I had this vision as part of Health is Global strategy to create an India portal and use the intellectual capital in NICE, the Royal Colleges, the CQC regulation, and including the work that is going on in research. So Muir and I have been talking about that, and have had, Muir has been there twice as well, and I've had a number of meetings. What I think is challenging at the moment is that whilst both parties understand that there's a need and how that need could be met, we don't actually have a business model. And what we are trying to do is to understand the business model for it. I think it works well on philanthropic side, and a lot of my effort actually goes on philanthropic exchanges. But charity is not cheap. To sustain charity, you need to generate funds. So Muir and I are at the next stage now, and if anybody has got clever ideas of how to turn it into a business model, we'll be very interested to hear from you.
Thanks, Raj. Any other questions or comments? Christine?
Thanks. I guess this is probably for Andrew. And it's another take, I think, in David's question. We're obviously sitting and pulling our head out about this. And just obviously you spoke about the work that's been ongoing in Scotland and the level of collaboration achieved under a number of different headings. And in answer to David's question, you spoke about the power of the network, the power of patient involvement, driving change. I think just to paraphrase very, very briefly. I think my question is really about in Scotland, have you seen that direct read into the various professional curricula in educational establishments, whether they're universities or whatever? Has that happened just organically, or has it been actively pursued so that we get them? We talked about that this morning, about actually getting into that early level of professional education. it coming through and expecting to work in the way that you described and indeed we've heard it described elsewhere today?
Yeah, good question, because that's where we've got to start. We're all old. Another hat is I'm a governor of the Health Foundation, and this is something that we discuss there frequently, is how do we embed this within the next generation of healthcare workers. And it's piecemeal in Scotland. I think in 3 medical schools now, we have quality improvement methodology systems and team-based learning embedded within the nursing and medical curricula. And I think that's really important. And they actually don't expect it, because we've just got this traditional model of being very patient-focused, disease-focused, therapy-focused. So we've embedded this within the curriculum, and we've done it now for about 4 years, and year on year we see improvements in the way that the students embrace it. And actually now a lot of them do special study modules on improvement systems, team-based working, analysis of data, measurement, all these things. I think that's really important. But sadly it's piecemeal. You know, we need to get into the GMC and try and make it mandatory, I think. Ironically, because everyone says, can you scale this? And in the last 2 years, I've been to Kuwait, of all places, 8 times in the last year, because we've set up a nation-to-nation collaboration, and we've put in a package of education, quality, service redesign, and the electronic patient record. And in many ways, it's going a lot quicker in Kuwait than it is back at home. So I think this model is scalable, but it's multifaceted, and you've got to start with the young.